Hello. This presentation was created by Dr. Donald Geriatric. We're going to discuss Part 2 of the geriatric assessment. Our topics today are how to approach the physical exam with older adults. We also want to focus on both functional assessment elements. We will talk about tools to conduct rapid geriatric assessment, as well as embedding geriatric assessments and management into primary care, focused around the 4 M's. We'll briefly talk about acute functional declines. Some of the key elements of a physical exam for older adults include orthostasis, or taking blood pressure supine and then upright. Oftentimes, older adults don't complain of lightheadedness and still have substantial drops in blood pressure that predispose them to falls. We also want to establish their baseline temperature. It's so important to know if somebody has a 97 Fahrenheit baseline temperature, because in the future, if they develop a 99.5 temperature, that could represent fever. We also want to remember that heart rate may not change significantly in the older adult, even if they're not beta blocked. If they are beta blocked, there may be a blunting of the heart rate response, which is significant in terms of measuring orthostasis or responding to acute illnesses, such as infection. A lot of times people with febrile responses or hypoxemia will have tachycardia, but you may not see that in the older adults. We always have to be reminded of the basic aging physiology as it relates to the driving force behind heart rate variability. We also want to use a 50-foot walk to test ambulatory pulse oximetry. A lot of times individuals will get short-winded and they'd find out that they desaturate their oxygen levels as a consequence of walking. We talked about temperature, and then gait speed is another key element of the physical exam. As we mentioned earlier, anybody that ambulates less than 1 meter per second with usual walking speed is considered at risk for falls, future cognitive impairment, and hospitalization. Let's cover these different elements of vision, hearing, and nutrition, and what the approach is for them. Vision can be very simply screened with a Snellen chart. They're always performance-based type screening. It would be good to ask the patient to read something from either a newspaper or magazine. Use vision screening with both corrective lenses and without. There is new evidence to suggest that individuals who wear bifocals may not be good if they have a fall history because the vision gets disrupted by the trifocals or the bifocal. With hearing, certainly looking for cerumen impaction is required. In geriatric assessment referral for auditory testing, it would occur if somebody acknowledges some hearing loss or if they failed the whisper test. That's where you're 2 feet behind the person, so they can't see your lips moving or read your lips, and then you ask them to repeat what you've said. With nutritional status, you want to look for temporal wasting. The temporal lobe is hollowed out. You may see that in anorexia, as well as failure to thrive syndrome in older adults. You want to look at the BMI. Ascertain whether they have low BMI, as well as high BMI, and importantly, to identify whether they've had more than 5% weight loss in the past half year. With the neurologic exam, some elements that I like to add for geriatric assessment are frontal release signs. You can see in this picture the snout reflex, but also you can have the glabella reflex, where you tap on the lower forehead. If the individual does not extinguish blinking, then that's a positive frontal release sign. The third frontal release sign is the grass reflex, which you typically don't see in the older adults unless they have some really significant frontal lobe damage. Check for cogwheeling in both arms. Sometimes you have asymmetric cogwheeling due to an ipsilateral stroke. For people who complain of dizziness or lightheadedness, do the Hall-Dix-Pike maneuver, which is represented in the right cartoon on the slide. Part of the neurologic exam is to examine cognition in various domains, with the main representation of memory loss being loss of executive function. That leads to evaluation augmentation. Typically, in older adults, we examine cognition, their memory capabilities, as well as their reasoning. Sometimes, this will include decisional-making capacity as part of that assessment. There are tools for decisional-making capacity. As part of the mentation, we want to examine whether they have depressive symptoms and/or anxiety. Older adults have more anxiety than they have depression. Doing regular routine screening for these different kinds of mentation issues is very important for geriatric assessment. The reason we do cognitive assessment in geriatrics on a routine basis is that most people don't complain of memory loss. Those who may have memory loss, some of it may be minimal cognitive impairment, or it may be frank dementia. They often don't report falls and accidents. Sometimes they'll defer a lot of questions to a spouse or family member. That could be an important clue that they may have memory impairment. Anytime an older adult in your clinic defers questions that you ask directly of them, it could be a good indicator of dementia. What do we have for cognitive assessment? These are all based on performance measurements. The easiest, very sensitive, and very specific one is the mini-cog test. Basically, you have the individual repeat 3 words. They do the clock draw test, and then you ask them to recall those 3 words. Remember, the 3 words always have to be different categories. For example, apple, clock, and flag. Something that has 3 different categories that have no relationship with one another. The other important point to make is when you have them draw the clock, it should be something after a clock. You want the hands on opposite sides of the clock. If they have asymmetry in their cognitive impairment, you'll be able to identify that through the dual hemisphere testing by a clock jar, where the hands are placed at opposite ends. If the mini-cog test is positive by an abnormal clock draw, or not being able to remember the 3 words, you then can proceed to a more definitive cognitive testing exam. We use the St. Louis University Mental Status Exam. It's gained increasing popularity because it's equivalent to the MoCA, Montreal Cognitive Assessment Test, and the Mini Mental Status Exam. It's free, where the other 2 examinations have proprietary rights. There's a charge for using those in a non-educational setting. Everybody's migrated to the SLUMS test. This assesses different elements of memory, executive function, abstract thinking, attention span, calculation, and visual spatial skills. Visual spatial skills are one of the first components of cognition that fail with Alzheimer's disease. That's always important to remember. This has some representative clocks. You can see how people distort the clocks. The smaller the clock, the more likely they might have something like Lewy body dementia. You can really tell a lot from how they draw the clocks. Sometimes it's very surprising to the patient themselves that they're not able to draw a clock. Sometimes you have the smart aleck who won't draw the clock, but give you a digital clock version. However, that goes in your clinical assessment. It's important for them to show that they can actually draw an analog clock. The SLUMS exam is a St. Louis University mental status exam. You can see the different elements here of questions that they ask. This does not take very long. The longest part is question 12, which is a short story about Jack and Jill who live in Chicago. There are several questions associated with recitation of that story. It's a point scoring system. If you're less than high school educated, you get a little bit of a bonus point. So if you score lower, it's less representative of the cutoffs for cognitive impairment. With psychological assessment, the PHQ-2 is probably the quickest way to identify possible depression. If you screen positive, you can move to the PHQ-9. This shows that as the score increases, the positive predictive value increases with the higher score. For social assessment, there's a variety of tools that are available. Generally, these are asked as questions that entail things like spirituality. Be sure to ask folks if they're church-going. If they don't go anymore, that could be an indicator of change in functional status, either cognitively or physical functionality. Ask what their social support system is, who they would turn to in times of crisis, and if there is an established caregiver. You want to try and figure out whether there's any caregiver burnout. The Alzheimer's Association has a pretty good tool for assessing caregiver burnout. Ask if they have any financial concerns. You can ask individuals if they've had any money stolen, taken, or misused. You can ask them, in terms of safety, how do they feel? Are they fearful? Are they afraid of anything? Of anyone? Sometimes you can find out some interesting things. There was a cognitively impaired older adult who had a squirrel problem and would try to shoot them. Turns out those squirrels were mistaken as children. He had Lewy body dementia. When you start misidentifying objects and people as something else that's somewhat delusional, you can identify that through things like social assessment. We also like to assess mobility. This is really huge. Most people, when they ask if they have a geriatric program, they say, "How do you assess mobility?" And they say, "We do the timed up and go test or the tug." That's a test where you get up from a chair, you walk 10 feet or 3 meters, and you return to the chair and sit. If it's more than 15 seconds, that's considered abnormal and would represent somebody who has a mobility impairment likely to have a future fall. It turns out that you actually do an 8-meter gait speed. So 4 meters is the distance that you measure, but you give them a couple of meters before and after to warm up and cool down. Slow gait speed less than a meter per second is a very strong predictor of future disability, future falls, and for future hospitalization. This simple test should be used more. If you look on medical charts, and particularly like in Epic where we use the electronic medical record, they have a risk for hospitalization scale. It's 8 to 10 different elements, and they give a score. If you look at the score, like if somebody had a gait speed of 1 meter or less, everybody would know immediately that this person is at risk for hospitalization. You would take all the appropriate steps for preventing that from occurring. This gait speed is so much simpler to use, and everybody understands it, as opposed to all these other elaborate risk factor devices. With the musculoskeletal exam, an alternative way to assess fall risk is to do what we call the sharpened Romberg. This is where you get both feet, send them semi-tandem, and then finally put the left foot in front of the right foot. If they happen to be right-handed, you always keep the dominant foot in the back securing foot, and then you wait and see if they start wobbling. Be at the ready. A lot of these people, as soon as they go into that stance, are about ready to fall, and it occurs very quickly, within a 10-second period. You also want to measure proximal muscle weakness, doing things like the shoulder shrug or a leg lift. Test for SOA stretching. That measures the hip extension. You'll be amazed if you apply this to your practice as to how many people have limited flexibility in their hip extension, as reflected by a PSOAS spasticity. In summary, our comprehensive geriatric assessment is basically a very complete history and physical that's been expanded with various functional assessments. If you can remember the geriatric 4 M's, that's going to give you the essence of geriatric assessment. We want to know what matters so that we can align the care of the patient with their health outcome goals. We also want to look at medication for opportunities to deprescribe. Persistent PPIs are detrimental. They're a predisposition. These proton pump inhibitors are predisposition to osteoporosis and to future C. diff colitis. If the individual is treated with antibiotics and screening fermentation, that's the other 4M. Looking for early cognitive impairment, which can actually be managed through adequate blood pressure control and increasing physical activity. Now there's emerging evidence that the type of diet you have may reflect on how rapidly your cognition deteriorates. Mediterranean diets seem to be protective. Omnivore diets are accelerants to dementia. Finally, the other 4M is mobility. The key there is to improve mobility and to prevent falls.